So what do we want for the physical therapy profession for the future? Do we want physical therapy to be a primary care profession? Do we want patients, instead of reaching to another 5 different providers before they come to us, be able to come directly to us and us being able to service them 100%? So if that is the case, then you have to change the way we practice, because a primary care profession, emphasize in preventive care, in health maintenance, patient education, as well as the diagnosis and treatment of acute and chronic illnesses in a variety of healthcare settings. So if we're not able to pinpoint properly the root cause of a patient's problem, then our solutions will be less than ideal. So it's something that has been already practiced in the military. And we know study after study, including the American Physical Therapy Association's value of physical therapy practice that was published this last year, is profound to show the cost savings for various conditions that measures sometimes to tens of thousands of dollars if patients reach out to physical therapy first. But look, these are the components of physical therapy as a primary care profession. Yes, we will be the first point of contact. Comprehensive patient evaluation, patient-centered care, longitudinal management, collaboration and referral, health promotion and prevention. But look what is included under comprehensive patient evaluation. Diagnostic testing, which can provide better patient outcomes. So, what are the diagnostics that a physical therapist can do? And I'm not going to tell you what the physical therapist can do, because in my viewpoint, and again, this is my viewpoint, and I've been advocating that forever now, physical therapists should have physician status. They should be able to order MRIs, X-rays, tests, blood work if needed, and prescribe medication too. And our education has been, for the most part, there to warrant that. It should be, physical therapy should be recognized by the federal government as physician status and paid as such. But this is not a future, it's a future task. It's not a task for the meek and the weak. It's a task for those for the lion hearts, I say. Okay, so, but currently, right now, physical therapists can perform by statute, by Practice Act in most states, and can bill insurance and get paid by insurance for electromyography testing, for musculoskeletal ultrasound testing, for somatosensory evoked potential testing, and for video nystagmography. So these are tools that can help pinpoint the source of a patient's problem. These are tools that can help physical therapists expand their practice, and these tests align with the overarching aim of primary care to optimize health and wellness. So here's an example. And the next 3 cases I'm going to show you, these are slides that a friend of mine, Bart McDonald, has shared with me, and he created them. These are real cases, real patients that walked into his practice. This is a 50-year-old construction worker with progressively increasing right shoulder pain. Okay? The pain has been worse, getting worse, disturbing his sleep, and starts feeling weakness. The patient was denied an MRI and presented for physical therapy before any other actions are considered by the insurance. Okay? And I have you here a little bit of manual muscle test and the stuff that they found on him. Okay. Why the patient was denied any other diagnostic test or anything? Because this is what happens. You have an injury, chronic or acute, you seek medical attention, the ER, the MD, or the physical therapist. You request to do an MRI because you feel that this patient has a rotator cuff there. You want to know this patient, is it a candidate for a physical therapy or it's a candidate for surgery? Well, you get a denial from insurance. Insurance tells you no. You have to get 3 or 4 weeks of physical therapy with no results before I give you authorization to get physical therapy. So essentially, to get an MRI. So essentially, what the insurance company says that you have to have failed PT after 3 or 4 weeks before you can get an MRI. So patient does an MRI, they have a rotator cuff, then they do operation, and then they are sent for post-op PT. Meanwhile, in the first 3-4 weeks, they have utilized all of their benefits towards failed PT. So what we're saying here is, what if when the patient walks in your clinic and you as a primary care provider, you are able to determine if this patient is appropriate for physical therapy or not? And if the patient is appropriate for physical therapy, you treat them. If not, you send them to the orthopedist for surgery. They come back to you for post-op. Won't that save more money to the system? But this is not what's happening. So this patient, when he came into the practice and looked like that, all right, just imagine if you were able to do this. Point of care ultrasound. Literally, in 5 minutes, you can stick on that patient's shoulder that ultrasound probe and you can see inside the patient's shoulder dynamically as the patient moves, not a static MRI picture, dynamic movement. So then, with that in mind, because you know what normal looks right here, you compare that normal to what you found in that patient, which looks different. Look at the right of the picture, looks nice. Look at the left of the picture, it looks horrible, right? So what you learn in these programs, in these courses, you learn to call this a supraspinatus tear with tendon retraction. And you are able then to make a determination what that patient needs. So instead of this patient needing 10 to 12 sessions of failed physical therapy, the patient needed to go get surgery and come back to do successful physical therapy. Case number 2, wrist pain with CrossFit. 42-year-old male, pain in the dorsum of the left wrist. The patient was doing CrossFit. The patient had to stop CrossFit because of that. Now, this patient was sent to another physical therapist for 6 weeks for physical therapy, doing exercises with manual therapy, mobilization, strengthening exercises. The patient went to Bart's clinic, recommended by his neighbor, who was one of their patients. I mean, the moment the person walked into the clinic performed an MSK ultrasound. This is what they found. They found a huge ganglion cyst at the dorsum of the wrist. No matter how much physical therapy you're going to do, no matter the strengthening, the lasers, the whatever you're going to do, I mean, that ganglion cyst needs to be removed. Unless it's such where you can pop it. Then it will, if the capsule is still there, it's going to come back. So patient was sent to a hand surgeon And now patient did very well with physical therapy afterwards. And the third and last case, 57-year-old female with long history of neck and thoracic pain and stiffness, numbness and tingling in both hands and in the left lateral upper arm, mostly digits 2 and 3. The patient is diabetic, he has rheumatoid arthritis, 4 weeks of physical therapy in a center owned by the orthopedist. So after 4 weeks, 12 sessions, 10, 12 sessions, the orthopedist says, you know what? I'm going to send you to do an EMG now. So the orthopedist, because he knew this does EMGs, he sent the patient for EMG. Well, I'm not going to bother you with these numbers now, what they mean, but what I'm going to show you here was that this test found that the patient had a median neuropathy on the wrist, carpal tunnel, and also a C7 radiculopathy. But look at this now. This test, guys, not only it showed that the patient had carpal tunnel, but those of you who are manual therapy freaks, I want to show you this. The EMG was able to identify that on the right side, the right median nerve had both demyelination and axonal loss. Both the myelin and the axon of the nerve was affected, while the left median nerve had only the myelin affected.